Welcome back. I am sure you enjoyed the concurrent sessions, which were very informative and educative. And I'm sure also they have energized us to give a voice to the silent burden without leaving anybody behind as we move towards 2030. I would like now to introduce our closing plenary, which will be moderated by Usaid. Is an obstetrician and gynecologist with clinical research and public health experience working around the globe. He is the head of the Maternal, Newborn, and Adolescent Health Unit at UNICEF headquarters in New York. After this important closing plenary, we will hear final remarks from Paul Bolton of USAID. So stay with us as our programming continues. Will, I pass it over to you. Good, sir.
I'm pleased to welcome you to this closing plenary, and I'm very happy that we have this historic first ever global technical consultation. And I'm very happy to be joined by esteemed colleagues who bring this unique perspective to this critical issue. I know that over the past days we have invaluable opportunity to share knowledge and challenges and successes. And the conversation has been really great. As an OBGYN myself, I've practiced 10 years clinically, and I personally experienced the possible consequences of maternal mental health and what can happen when maternal mental health is being neglected or not taken seriously. And it's an overlooked issue. I believe that it's important that we look at this at this convening. I know I speak for many that this technical consultation has reaffirmed our commitment to advance action for maternal mental health. But it's important that we ask ourselves tough questions, challenge the status quo, demand meaningful, lasting change, and identify next steps for global, national, and local maternal, newborn, child health, nutrition, and mental health, and also overcome the challenges we know and ensure that every woman has access to mental health care and that they deserve. There are key barriers that persist, and we have to make sure that we overcome them. And there are immediate short-term actions we can take, and that spur action. And so for this closing plenary, we have the opportunity for all of us and all of you to hear insights from our speakers on these issues and contribute to a growing movement to advance collective action on maternal mental health efforts. I want to introduce our panel, of course, and the first panel member is Anshu Banerjee, who's the director of the Department of Maternal, Newborn, Child and Adolescent Health and Aging at the World Health Organization. He previously served as the director of global coordination and was also WHO representative in Albania and Sudan. Our second panelist is Joy Burkhardt, who is the founder of 2020 Mom, which is a nonprofit social change organization working to close gaps in maternal mental health through education and awareness. Joy has inspired to found 2020 Mom after she had several personal experiences, and she's recognized as in a unique position to bring to us why mothers are not treated in the way they should be treated for mental health disorders. And not being treated in the same way as medical conditions. Then we have Kim Dixon, who is the Senior Advisor and Chief of the Maternal, Newborn, Adolescent Health Unit in UNICEF in New York. Kim is a physician, a women's health advocate with 20 years of international experience, and she worked on national and international level on several continents across the world and has worked for several UN agencies, including WHO, UNICEF, and UNFPA. Then we have Mwawi Ngoma, who's a PhD fellow registered with the University of Malawi College of Medicine, obtained a diploma in general nursing and a certificate in midwifery, and now proceeding to work in community services. She became a state registered psychiatric nurse in 2001 and worked 3 years as a psychiatric unit manager and has on-the-ground experience. She's also having obtained a master's degree in nursing specializing on mental health. Then we have Mikram Patel, who's at the Pershing Square Professor at Global Health in Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. He's co-leading the department's mental health for all lab and co-leads the global mental health at Harvard initiative. His work really focuses on burden of mental health, problems across the life course, disadvantages. He's the co-founder of several initiatives, and he was in 2015 in Time magazine being one of the 100 most influential persons in that year. And then finally, we have Marie-Tou Satin, who is the chief of the Maternal Newborn Health Service Division in the Office of Maternal Child Health and Nutrition at the Usaid Washington. Marie-Tou is a Foreign Service officer with more than 20 years of experience in international public health and development, and has served in a variety of leadership positions across several countries, including Afghanistan, Guinea, Bangladesh, and recently in India. I'm really glad that we have such an esteemed group of panelists that will speak to us now for the closing. And I think it's a nice wrap up for us to look into challenges in the status quo, but also to the future and what the next steps will be. Before we begin, just for process, how will this work? We will have question and answers with the panelists. It will be 2 rounds of questions. Each panelist will speak to the first question, then the second question from their perspective. And I will open the microphone from my side when there is 1 minute left for the speaker, so the speaker knows that it's time to come to an end. So with this, I would like to turn to the first panelist, Anshu Banerjee, and the question will be the same for all of you, but I will form the question specifically to you so that you know how to respond, what we would like to hear from you. So Anshu, what are the key barriers in maternal mental health? What is the status quo and what are the challenges? Being the director for maternal, newborn, adolescent health and aging at WHO, how do you see the challenges in the status quo working for an organization that is developing guidance and global guidance and technical guidance? Over to you, Anshu.
Thanks, Will, and it's a pleasure to be here. Maybe just to highlight that maternal mental health, of course, has a major impact on the mother, but also their partners and their families. And this applies to all countries in all settings, whether it's a high or a low-income country. And we know that approximately 15% of women experience common mental health disorders during the antenatal period, and about 20% have those common mental health disorders in the postnatal period, but only 20% of them actually seek care for that. And so one issue is really how can we make sure that we have better measurement around this and that we can strengthen our monitoring around this. We have global data on the burden of maternal mental health, but we have limitations within that as well. And it's really important, first of all, to be able to highlight this, because we know that the impact on the mother leads to, let's say, poorer health-seeking behavior, either during antenatal care or postnatal care. It also leads to maybe substance abuse, smoking and alcohol that also has an impact on her pregnancy as well as on the well-being of the child. And potentially also it could lead to suicidal tendencies. And in the long term, the outcomes can be, of course, low birth weight for the baby and stunting. So it's really an important issue for us to address. And besides that monitoring, it's important also because, as I mentioned, only 20% of women actually seek support for that. And that is because there's so much stigma associated around maternal mental health issues. And so we need to be able to address that. One of the gaps that we have is that it's maybe not well represented in the guidance and the guidelines that we have. We know that this is an area that we want to strengthen, and we want to make sure that we will be able to reflect maternal mental health in guidelines and in guidances that we issue, and make sure that these are introduced in the different platforms for service delivery. Another major limitation, I think, is that we have a shortage in the health workforce. We know that only 1% of the global health workforce actually works in mental health. And so in order to be able to address this, we really need to build let's say, their capacity in order to be able to screen this and manage maternal mental health issues. And that maybe brings me to my final point, and that's that we really need to have advocacy around this. And we need to be able to develop the right kind of messages for the different kind of target audiences that we want to convince, let's say, of investing more in maternal mental health. And this can, of course, range from policymakers to program planners to civil society. So I think those are a number of the key challenges that we face at the moment, and that we need to address in the future.
Thank you, Anshu. That's I think a great way of laying out the issue. And you were talking about shortage of workforce. I think that was also mentioned in the other sessions, but also advocacy and how WHO is so important in terms of the guidelines and guidance that we need, and the technical guidance where other UN agencies very often collaborate and also chip in. Next, I would like to ask Joy the same question. So what are the challenges in the status quo that you see? You have founded 2020 Mom, I think a very important non-government organization that really brings the issue up to a higher level, also in the NGO community, and also above that, and maybe also on the ground. In relation to the challenges and the status quo, how do you see system changes, policy changes, and maybe you can also touch on stigma, what Anshu also mentioned.
Absolutely. Thank you, Will, and good morning from the United States. I'm very pleased to be here. I also want to thank Usaid, Momentum, and the World Health Organization for your leadership. This is foundational work to help lay the path forward to bring all of us together from around the world to discuss this important issue. So thank you. I also just want to recognize that I think all of us are here with a lens that it's important to center the mother. We need to ask ourselves, is the health delivery system working for and meeting the needs of the mother? If not, right, all the efforts that we may put in place still may not help the mother feel comfortable and access the care that she's looking for. The other thing I want to share is that my background is as an MBA. I'm not a clinician, and my lens is on scaling change. I really believe that it takes government leadership as governments play a role in developing infrastructure and keeping us safe. It must require a government response. And as I mentioned, I'm based here in the United States, and just really pleased to share a little bit about our perspective and what's been happening here in the US. I also want to acknowledge that it's the week of Maternal Suicide Awareness Week, and so appropriate for all of us to be here together now. I wanted to start by sharing my perspective of what a foundational barrier is in this space is fragmentation and lack of integration. I know we've heard this over and over from various speakers. What I really mean when I say fragmentation here in the US, and I think beyond the US, is that our medical care systems and our mental health care systems do not always connect. And that is a foundational problem that we must address. Otherwise, I fear all of the other actions we may attempt to take will not succeed in the means that we want them to. Here in the United States, that fragmentation issue is really rooted in payment systems. We have different payment streams that support health delivery and mental health delivery. Until that changes and the payment streams are one and the same, we will continue to have problems. The other opportunity I see is barrier I see is sort of lack of centralization. Where are the centralized guidelines from each of our countries? What do clinical practice guidelines really look like in this space? Who's monitoring against those guidelines? And assurance of adequate providers to implement those guidelines. Here in the United States, we found that it can take up to 17 years to adopt a guideline. That is much too long, particularly for those of us in the maternal mental health space. This is an issue whose time has come, and 17 years is just too long. It's going to take issuing standardized guidelines, but also overseeing implementation of those guidelines and measuring what we treasure. Is implementation actually happening and working? I also wanted to say that I think that one of the key barriers is that it's just so complex for healthcare providers right now, and that simplification is really necessary. And what do I mean by that? It's that inevitable question, okay, if I screen for a maternal mental health disorder, then what? What screening tools do I use? I know that it's not just depression. I'm worried about psychosis and safety. What about OCD and intrusive thoughts? That's all very confusing. What screening tools do I use? There are solutions that I think we can adopt there. And of course, the simplification piece must include linkages to support and treatment. And then we heard Anshu already mention provider shortages, and Will as well. To plan for assuring adequate number of distribution of healthcare providers is going to be critical. We'll talk about more about those potential solutions here in just a minute. I like to think about it as government infrastructure in the US includes sort of adequate assurance for the numbers of public schools, yet we don't seem to have anything similar in place for health delivery and mental health. I'll also add that here in the US, after COVID, the whole state or the whole country of the US, all of our states are considered mental health shortage areas. That wasn't the case prior to COVID. And now with the onset of increased anxiety and depression nationwide, that's becoming a problem. I think there's a great opportunity for federal agencies to become coordinated and provide central oversight on all of these fronts. And Will, I'm also really excited to talk about stigma and solutions there. Stigma is certainly an issue, and I wholeheartedly believe that healthcare providers are the number one answer to solving the stigma crisis, which we can talk about in just a moment. Thank you.
Thank you so much, Joy. I think these are very interesting insights. Also that you said, there's a maternal suicidal week you were saying. I was not aware of that, I'm sorry, but it's really, it's great to hear that there's advocacy. And also, what you were saying around guidelines, that they take a long time. I think it's important that exactly this is why we are here, to support this process and make sure it can be expedited. Next, I would like to turn to Kim. So Kim, the same question, what are the challenges and what are what is the status quo? But working for UNICEF from a perinatal child perspective, how do you see the challenges in the status quo?
Thank you, Will. First, let me thank the organizers for inviting me and UNICEF to be part of this closing panel. I want to say firstly that maternal mental health is actually a relatively new area within our UNICEF programming. I'm sure that won't take many of us as a surprise, but just to say that on its own is quite a challenge because we haven't really prioritized maternal mental health. Currently, we are looking at maternal mental health through our adolescent work. As we look at our adolescent health programming, we are beginning to see what the magnitude of the problem is, and we are working to address the issue through that lens. Also, maternal mental health is often very missing in maternal health services or maternal health programs on the ground. There's a general lack of awareness and services for mental health, and that alone is a challenge. But even when there is some awareness of maternal mental health, then you note that counseling and support, so the response to the problem, are also quite a challenge, and we're not doing much on that front. Recently, this COVID-19 pandemic has disrupted our maternal newborn service delivery. So we realize now that there's a disruption in access and quality of the services. And as the COVID-19 pandemic has impacted the perinatal experiences and mental health of mothers. So with this pandemic, we actually have an increase in mental health issues. And we've also found that there's been decreased mother-to-child attachment during the period. So we recognize also that respectful maternity care, that we are not providing mothers with the quality of care that they should be getting during the COVID-19 pandemic. And this has led to heightened anxiety and stress. And we're also noting more mental health issues amongst mothers, and also leading to family disruptions and instability. But I would also want to mention that as we look at the issue of maternal mental health, and as we look at how we strengthen the service delivery, first the recognition of maternal mental health, and also the response to maternal health, I think that a big challenge is also looking at the healthcare providers and providing them with the support that they need as we capacitate them with the skills and resources to support mothers. So for me, the maternal mental health is an issue both in terms of our recognition of the problem, in terms of our response to the problem, and then also in terms of our support for those who are supposed to respond to the problem. So these are just a few remarks I'd like to make on this issue. Thank you very much.
Thank you, Kim. And I think it links also to what Anshu was saying. Anshu was saying we have a lack or shortage of workforce. And you're saying we need to train them and give them the skills and the tools for those that we have. And also interesting that you said, you know, and certainly true that maternal mental health issues can lead to disattachment between the mother and the child. So the child is definitely affected also in that way. Thank you for giving that perspective. I think it rounds very well up to what others have said. Now I would like to turn to Maui, and same question: what are the challenges and the status quo? But probably, you know, since you have really worked directly and in the field and with people and in hospitals, what is happening in the community? What are the measures that are needed to support mothers and babies in the community, and how can we make those linkages from the community to the health system?
Thank you so much, Will, and the organizers for giving me an opportunity to participate in this important dialogue. I just want to begin by saying that indeed, as a practitioner, there are a lot of challenges on the ground. And also just to echo what the previous speakers have talked about, the major issue that we see is the lack of awareness. Indeed, maternal mental health issues are not well known in our setting. And there's very little that is being done in research as well as in practice. And indeed, majority of women or mothers are suffering in silence. So I think meetings or gatherings like these ones are very important because then we are able to share experiences and best practices on how we can push maternal mental health agenda forward. And in the work that we've been doing in the past 3 years, we found that majority of women do not think that what they're experiencing is a health issue. And then they are unable to go to the hospital to seek help. So that is a major burden to healthcare. And this is worsened by the belief system as well as stigma related to mental illness, as it was also alluded to by the previous speaker. So these also affect even the ones who maybe might have realized that this is a health issue, that they need to seek care. You might find that also they meet challenges within the health system because the health system itself is not properly capacitated to handle maternal mental health issues. So we've been looking at ways of supporting mothers in the community, as well as those who have serious mental health problems. First, let me mention that also because of the shortage of staff, especially at PHC level, where majority of mothers seek care, you'd find that there is quite a huge gap for women who require the service and those who are able to access it. So we've been trying to create awareness in the community so that at least the women as well as community member in general are aware of this issue. They should be aware of maternal mental health problems that women go through in pregnancy as well as following childbirth. We've also tried to provide training, orientation training to healthcare workers, mainly those who are working in child and maternal health services, so that they can be able to appreciate the problem, but also identify the problem and the ways of managing it. From there, we've also been providing treatment. This is medical treatment as well as counseling or psychotherapy for those who have serious mental health problems. In outreach clinics within their communities, but also in static outpatient clinic, and then in the residential care as well. And then from there, we also have been able to assist the mothers following childbirth so that they can be close to the baby. We admit the mother as well as the baby, of course, separately. But we've also looked at what is already available in the community, because most of the times we have relations with the mother-in-laws or grandmothers who assist the woman to take care of the baby. So in this time, we also invite them to come into the hospital with the mother. So as the mother is receiving care in the residential unit, the grandmother or the other relation is supporting with care of the baby. But the mother is given an opportunity to continue bonding and taking care of the child. We've seen that this also reduces separation anxiety that mothers would have if they're admitted in a mental hospital and then the child is left back at home. So these are some of the issues or the measures that we've tried to do to help the women. But also after care, we've looked at ways of how we can bring the women with lived experience together so that they can support each other. So we've facilitated formation of support groups where women are meeting frequently, and then they are supporting each other. However, with the advent of COVID, there have been challenges in women meeting together. And then we also had worked with several partners in trying to support the women. We worked with Maternal Mental Health Scotland, but also with Tropical Health Education Trust of the UK that had supported us in trying to acquire ways of how these women can still remain in touch through other media. So these are some of the initiatives that we've put in place to support the women right from the community, those who have serious mental health problems, but also after care. Thank you.
Thank you so much.
Over to you, Will.
Thank you. And you were saying there's lack of awareness in the community. So this is the triangulation, I guess, the healthcare provider, the community needs to be aware, because if there's no awareness, there's no demand. And even if you have staff who's sitting and waiting for patients, patients would not come because the awareness is not there. Orientation training, you also mentioned, and treatment. So I think the picture is coming together, and that fits probably well to ask Vikram what the challenges and what the status quo is. And you're being a psychiatrist yourself and being a very esteemed, established expert or global expert in this area. How do you see the burden in mental health problems, but also social disadvantages? And we have not heard much of prevention. If you had some ideas around that in terms of challenges there as well.
Sure, thank you very much. So first of all, I want to draw on my decades of work in this area, particularly in maternal mental health in very many different contexts across the resource spectrum, places like India, Zimbabwe, Uganda, and currently in the US. And I think one has to, first of all, accept the real big challenge, which we have heard about already by other colleagues, is that virtually all countries have failed to address maternal and indeed more generally population mental health needs, no matter actually how much political will is there behind mental health, no matter how much money is spent on mental health, and no matter how much mental health resources are available. And we heard from our colleague that the US, which actually spends more per capita on mental health than virtually any other country. Indeed, there are more mental health professionals in New York alone than the whole of Africa. And there are yet large pockets of unmet need, even in the US. So let's be clear that there is a fundamental problem in the way we approach mental health. And I think what I have done over the last many years is to try and do a deep dive as to why, in fact, unlike any other domain of health, from COVID-19 to HIV, in the mental health area, almost every country is a developing country. And so here is really where I think the real problem lies. I think the fundamental problem lies in that we have tried to mimic a very narrow biomedical approach that has worked very well for infectious diseases, for example, and applied the same framing for mental health problems, so that we try to divide people up into people who have and do not have a mental illness, even though, in fact, there is no scientific foundation to support this kind of binary approach. It means, for example, in the US, that care needs a diagnosis. And as we heard, reimbursement can only be done if that care is diagnosis driven and is done by a mental health provider. There's lack of attention in almost all care programs to social determinants, so that women are expected to deal with their social factors that almost always coexist with mental health problems through some other resource, which of course does not exist in most women's lives. There's a lack of a life course approach. Even though we know that most mental health problems have their origins before the age of 18, how often do we really think about prevention through a life course lens to address vulnerabilities in the early years of life? Mental health problems don't miraculously appear at the age of 24. They often have histories that go back many, many years earlier. There's lack of tailoring to the needs of specific subgroups. For example, young women, who are a particularly vulnerable group in many parts of the world. And of course, this is also the demographic that's likely to be represented in a significant way in perinatal populations. Or indeed other kinds of subgroups, for example, low-income women or women who belong to refugee communities. There's a lack of skilled providers if we define skilled providers in a very narrow biomedical way. That is to say, these are mental health professionals. But in fact, there are many other kinds of resources, but we have systematically, through a biomedical approach, disempowered those other resources. And finally, there is the big elephant in the room that people in the community do not define their distress through a biomedical lens. I have rarely met a woman who is depressed who actually conceives of her problem as a mental health problem or a mental disorder. And therefore, it isn't surprising that very many large numbers of women do not want to seek help from a mental health professional, both due to stigma and cost, but also because of very different ways of conceptualizing mental illness. I'll speak about the way forward in the second round of questions, but I wanted to end by just reminding ourselves of the grave contemporary threats to women and mothers' mental health posed firstly by COVID. I think we all are aware that in the pandemic, women's exposure to domestic violence, the increasing household responsibilities in highly patriarchal contexts, including childcare, as children have been shut out of schools, the early marriage of women because parents are marrying them off, and of course, the lack of access to services that we've heard about. And then finally, the second major threat, the continuing hardlining of an approach that robs women of their fundamental rights, including their reproductive rights, that we see in very diverse places, all the way from Afghanistan to here in the US. All of these are very important threats that we need to confront if we are to prevent the already serious unmet needs for mental health care from getting worse.
Thank you so much, Vikram. And then also you brought at the end the COVID pandemic that is of course worsening, and the reproductive health and rights that are also at stake. And I really liked the way that you built this up and all the points that you made also saying that we should not mimic and we should not look at infectious diseases, for instance, if we look at maternal mental health. Very valid points. Thank you so much, Vikram. And then last but not least, Marie too, the same question, what is the status quo, what are the challenges, but also what are maybe also stigma and the human in the center across the continuum of care. Maybe you can also touch on that. Thank you.
Absolutely. Will, thank you very much. It's really a pleasure to be here today, and thanks for this absolutely very important question as we look forward to 2030. First, I would like to say how much I enjoyed listening to all my panel members, and each one of them touch on the critical issues we face globally and in less developed countries in particular. So mental health support and treatment is complex and requires regular access to mental health care professionals and a variety of support services. Unfortunately, these care services are not always available or are underutilized, as we see. The global mental health treatment gap is extremely high. All these are due to the common barriers that we are all aware of, and my fellow panelists touched on already in their remarks, which I will emphasize to continue to make the point, to say it out loud, especially to this group that has the technical power and leadership to inform change in this area. The common barriers I see as challenges to providing mental health care to mothers, adolescents, and children include the availability that most of you touched on again, and also the affordability of this care. There is a lack of trained providers. When available, those who need the care cannot always afford to pay for their services. Access to medication is another huge issue that I haven't heard, but without the medication, to support the counseling that are provided to patients, those who need it, I think we are just halfway to addressing the issue. The health system is, by and large, not ready to tackle this issue. And this is where our work should start. I, however, think also that the foundation of this problem is truly exacerbated by insufficient mental health care policies. The leadership and decision makers are not at the table to communicate plans, to make services available and pay for them. Funding is a critical issue. Without the funding, we are not going to see an implementation, and especially a comprehensive implementation that addresses not only the physical health of those who need it, but also their mental health. The leadership is lagging behind. The lack of education about mental health illness, and that we see in both developed and developing countries. There is absolutely limited knowledge about mental health and can prevent also individual from recognizing mental illness and to seek treatment. There is a poor understanding of mental health, which also weakens families to provide adequate care for relatives, and that is sad. Stigma, I think each one of you did touch on that. It's still a huge barrier to access as patients protect themselves from social exclusion. I often wonder if policymakers also fear that same stigma that those suffering from mental illness fear, because we have seen in early years of the HIV/AIDS epidemic, for instance, that those who champion an issue tend to be very much associated with the issue. And that's a question I always ask myself. And this is, if this is indeed, the reason why we don't see, a lot of many leadership coming to the table and policies to follow and our funding as well. So addressing our mental health as part of our comprehensive packet of our services is extremely important so that we can reach our goals to 2030 and make sure that those who deserve it enjoy our exclusive well-being. And I'll stop there, and as we are running out of time. Thank you.
Thank you, Marie. So leadership, very important, policy development, and also lack of medication you mentioned, something we have not discussed yet. But the leadership and then making sure there's no social exclusion, that maybe also goes back to the point that Vikram made. The pandemic might worsen the social exclusion even and worsen the situation. So thank you so much for your comment on this. Yeah, I think it rounds up nicely the first question. So we had the challenge and the status quo. I think that was the easier question. The more difficult question is coming now. It's, what's the way forward? What can we do? What are the immediate steps? And what are the long-term steps that we need? And closing this convening, that's the main question I think that we want to bring. So I have to turn to Anshu again from a WHO perspective. When you look at WHO and how you work as an organization, what are the short-term actions? What are the long-term actions? How can we ensure that maternal mental health remains a priority as we move forward? How can we inspire others that they join us in this movement?
Thanks, Will. And, I think the first thing that we should really do is to ensure that it is included in our relevant guidelines, let's say. So we need to make sure that maternal mental health is incorporated there. And in our postnatal care guidelines, which hopefully will come out early 2022, we will be able to incorporate recommendations around that. The other process, of course, is how do we update recommendations more quickly? I mean, we have already heard that preparing guidelines and updating them can take a long time. And in WHO, we're looking at a process that we call the living guidelines process, so that when more evidence is coming out, we can update those specific recommendations. And at a process that we call the SMART guidelines, let's say, to really make sure that the guidelines can be disseminated more easily and through digital platforms. So that's one area. The other area I think that's also very important is to make sure that they're not only in the guidelines, but also in the practice tools. And many of these practice tools are jointly with other partners. And so some of them are, for example, the pregnancy, childbirth, and postnatal period tool. And we're now developing an interprofessional midwifery toolkit. And we need to make sure that maternal mental health is included there. And so, for example, for the midwifery toolkit, this is indeed the area where we're looking at a module for perinatal mental health. Another area that really needs support is to make sure that maternal mental health is included in our programs. So in our service delivery platforms such as antenatal care, postnatal care, during immunization visits, under 5 visits, and that we make sure that this is part of prevention, screening, and care. And so we're looking at really how to strengthen this, and we've done a mapping of resources to already look at what we can address. And maybe another area is also on the monitoring side, which I highlighted earlier, and is to have a robust monitoring framework so that we can better capture, let's say, the burden of disease and also track it better. And finally is to strengthen health workforce capacity for screening and management of this. And so that is besides just addressing the gap in the health workforce as numbers, but also strengthening their capacity. Some of the long-term areas would be really advocacy, as highlighted already, in order to ensure that there is going to be sustained investment in maternal mental health. We need to be able to reduce stigma, and so this can be through advocacy at the global level, but also through community-based interventions. And finally, maybe a point around research, and that there's really the need for implementation research to look at how to scale up prevention, screening, and evidence-based care in different contexts, and also to really look at the weak evidence base maybe that we have, and to make sure that we can identify and have a global consensus on research priorities that we need to look into. Thanks a lot, Will.
Thank you, Anshu. So long-term sustainable investment, I think that's important, as you said, research. And short-term, you were saying that there are several guidelines where actually maternal mental health can fit in very well. So we don't need to develop them at new, but then at the same time, we need new guidance and recommendations. You mentioned postnatal care visits and so on. So integration, I think the integration piece comes in again. How can we integrate and use what we have already? Thank you, Anshu. Now turning to Joy, it's the same question. What is the way forward? What are the next steps? You're working, having founded this NGO that you're leading, I think Advocacy and the way forward, I'm sure you have concrete ideas, so that we'd like to hear that.
Yes, thank you so much, Will. I want to share that I think one of the foundational steps that we must take and make is to lift up the cost of untreated maternal depression and maternal mental health disorders. Here in the US, a study found that it costs US $14.2 billion not to detect and treat these disorders. I wanted to focus on 4 buckets of solutions and also acknowledge that prevention, as we've heard previously, is critically important. It's not our focus because we're focused right now on ensuring the health system works when a mother is suffering. But I wanted to acknowledge that I wholeheartedly agree. It's a track that we must put attention on as soon as possible. So the 4 buckets I wanted to focus on that really must be addressed all at once are this issue of centralization and lack of guidelines, stigma through what I call screening efforts, shortages and support, provider shortages and support, and then science, implementation science, as we just heard Anshu address. So this issue of centralization, I mentioned in my comments about barriers, is that I really believe every government, both country and state or territory, should have a plan in place and address this issue of fragmentation. It should set the floor, a centralized coordinated effort that includes oversight that sets the floor, not the roof. So what are the minimum necessary guidelines that providers should be thinking about as they do this work? And that task force should be appointed experts, including experts involved in the delivery of services. As we talked about, sort of implementation is critical here. Here in the US, there's a new piece of legislation called the Triumph for Moms Act that really puts forward a recommendation to form such a task force here in the United States. In addition to centralization and addressing those issues, stigma, as folks have mentioned, is critically important in raising awareness. I believe that it's not just about public awareness and community awareness, so that really providers, healthcare providers, because these are biological disorders, really have a unique position to address stigma, or a unique position. And the greatest way to combat stigma and shame and misunderstanding is for providers to screen and, of course, treat, which means we have to put follow-up processes in place. And until we have screening in place in our obstetric settings in particular, as primary care settings, I believe that stigma will continue to prevail until women really hear that this is the #1 complication of pregnancy from their health care provider. I also wanted to share that I do think that this concept of a blood test, not just pieces of paper and check boxes, should really be prioritized. It would address stigma, it would simplify screening and detection for providers. Of course, very complicated, but something that I think should be invested in. Provider shortages, we've already talked about this barrier, which is critical. to solving this problem. We heard that many women don't speak up and don't seek care. Here in the US, many women do actually speak up, usually after long periods of suffering, and find that care is not available. And in part, as the speakers have addressed, it's available, there's shortages, and or there are availability of providers at very high costs that aren't addressed usually in the health delivery system. Patients have to go outside of the healthcare delivery system to seek care. A novel approach that I think we should not fail to address here is this consultation of obstetricians, for example, as a primary care providers, with psychiatrists or experts in the field to address the issue of access to drug treatments in particular and increasing provider capacity. That is a novel approach that really should be addressed. I also wanted to share, we talked about mental health provider shortages here in the US, and I know elsewhere, there are also obstetric provider shortages, and this must be addressed as a baseline issue. Increasing the access to midwives, doulas, and others is critically important. And then in terms of next steps around mental health capacity and provider shortages, we really believe that peer specialists, community health workers who are trained, tested for competency are the answer here. Not only will we increase the availability of professionals to provide services, we will meet women where they are, and this is critically important. We also believe that peer specialists have an opportunity to provide care coordination. So if a healthcare professional like an obstetrician does identify a problem, the then what can be answered by use of a peer specialist who's also trained in care coordination to make sure that the mother is patched to appropriate support, evidence-based support, and also addresses what she would like to receive as treatment. And perhaps she doesn't want a medication, and that's okay. What other services exist? And then finally, as we've heard earlier, my last bucket is science, and I really want to emphasize implementation science, as we just heard Anshu and other speakers address. Here in the US, the National Institutes for Health and Mental Health have said many years ago, we already know what works in terms of treatment. Now we need to fund models to test implementation. And those models really need to be rooted in this concept of who's paying for it. If we want ongoing sustainable models that work, we have to look at reimbursement and make sure reimbursement is addressed in, or payment is addressed in, those solutions. Thank you.
Thank you, Joy, for outlining your 4 buckets. Actually, I like them. And you also mentioned something what I like, that was meet women where they are. It's important that we make sure that we, especially when there's no awareness, we have to probably also go and seek for women and make sure that we support them where they are and not try to bring them to facilities. So the 4 buckets. Thanks, Joy. Next, Kim, the same question, way forward, next steps, working for UNICEF, child-focused organization with many maternal and newborn and child. What's your take on that? What's the way forward? Maybe smaller steps. What is the longer vision that you foresee?
Thank you, Will. For me, I really want to call us a call to action on this issue of integration. We really need to see how we can integrate maternal mental health services into maternal newborn services. And we do have many opportunities, because as mothers come for antenatal, they come for childbirth, they come for postnatal care, we really need to see how we can integrate their maternal mental health into these services. So ensuring that the guidelines address this continuum of care so that we have maternal mental health fully integrated. And as mothers come, they're screened for mental health services. But also, as we talk about integration, I like what the previous speaker, Joy, said about meeting mothers where they are. We need to see how we integrate maternal mental health services into our community and primary healthcare levels. So we get the services closer to the woman in their home environment, so closer to the primary care level. So for me, integration is a big issue. So integrating into the continuum of care, but also integrating into the primary and community levels so that we can reach many more mothers. Another issue for me really is talk about quality. So as we improve the quality of maternal health services, we need to ensure that maternal mental health is part of that quality of care. And we need to work to ensure that providers have the capacity, the tools, and the resources to address maternal mental health as part of these standards of quality of care that we talk about for maternal newborn services. So quality to me is an issue, and we need to look at quality of care in that lens, in ensuring that the care we provide for mothers and newborns is that holistic care, and it includes screening for maternal mental health. Now, even as part of quality, as we are working in many countries to restore service delivery after the disruption of the COVID-19 pandemic, we need to ensure that we really work to we institute these evidence-based practices, such as kangaroo mother care, such as breastfeeding. As we strengthen the counseling around these areas, we know that we can have some impact on maternal mental health, as we've shown that kangaroo mother care and breastfeeding are important interventions in supporting attachment, stress reduction, and lowering depression amongst mothers. So as part of restoring or strengthening health services, we're also addressing maternal mental health. I also want to emphasize, as part of the way forward, that advocacy and awareness for reducing stigma associated with maternal mental health really needs to be addressed, because unless we actually know what the problem is, unless we are aware of the problem, then it's very difficult to address the issue, the problem. And so advocacy and awareness also need to be highlighted. So as we work to strengthen maternal newborn services that have been disrupted by COVID-19, also we need to take the opportunity to integrate maternal mental health as part of the quality of care that we provide. Thank you.
Thank you, Kim. So I think you brought out very important points about the integration and the quality. And I think it links also very well to what's happening in the community. And the same question I would, as a bridge over, ask Mwawe. So what is your take on the way forward and the steps that we can take? And we have to wrap up at some point. So if we need a little bit shorter answers, I'm sorry to say that, because we're running out over time already, but of course we want to give enough space. So Mwawe, over to you.
Thank you so much, Will. In the short term, sorry. In the short term, I think what is important really is raising awareness and advocacy towards policy change and action. Because what we've noted is that there is a lot of work that is being done independently. So research or some other interventions that are done separated, that they need to be packaged together and then bring the policy makers to a round table so that we can have this kind of dialogue or conversation that we can push for action. Because for an example of Malawi, there is now inclusion of maternal mental health into reproductive health standards. However, there is no action beyond that. So it's really important that we push for action, which will also include emphasizing on the funding, because funding really becomes a major challenge when it comes to moving forward or implementing beautiful things that people have planned. I also just wanted to briefly talk about one of the important tools that we might have as African countries. We now have an alliance for maternal mental health, an African alliance for maternal mental health that we can use, because this is an all-inclusive alliance that would have various stakeholders who would come together and then have a collective or strong voice that can be used to push this agenda. And also emphasizing on exploration on task shifting as well as or task sharing, because we've seen that the traditional healthcare providers are quite overwhelmed. They might not be at a position that they can take up such roles. So it's very important that in our setting, we also look at these resources that we have and then make use of them. In the long term, I think we really have to push for integration of universal screening of women in antenatal care, because currently where I am, there is no routine screening, there is no intervention. So that would be a starting point for women to be connected to care services, but also training for health workers at all levels, starting from the community as well as secondary level. And then lastly, intensifying information, education, and communication materials, which can also initiate help-seeking behavior from the community. Over to you, Will.
Thank you, Mawi. So integration comes up quite often, I think, and you have just confirmed that. That's great to hear. I want to now ask Vikram, what's the way forward from your perspective? What are next steps and the long-term steps that you have in mind?
So I want to fully support, what all the previous speakers have said and not repeat it, but basically integration of maternal mental health care within existing maternal and child health services has to be the way forward. But let me remind us that we've been hearing exactly the same call for about 30 years. And I think the question really here is what's going to make a difference? We've heard repeatedly the need to build resources in the community, to build a community foundation of care, to scale up the very rich evidence of task sharing, of psychosocial interventions that do not take a diagnosis-focused approach, that leverage existing community resources, both community health workers, but also peer support workers. All of this is actually not new. It's been around for decades. The question is, why does it not get scaled up? And I believe the real problem is that we are sticking to a very old-fashioned approach on training, on support, on supervision, and quality assurance. And secondly, that these community approaches are not coordinated with the rest of the healthcare system. They're often run by NGOs, they're often run in small-scale demonstration projects. I do not actually know of anything that's ever gone to scale almost anywhere in the world. And I think what we need to do is to now embrace innovative new solutions for training, support, and supervision. We at Harvard Medical School, in partnership with partners in India, Britain, and elsewhere, have launched a platform called Empower that is seeking to digitize the entire process through which frontline workers, peer support workers can learn evidence-based psychosocial interventions, can then master those interventions and can deliver them, all while they're actually doing the work that they do, rather than calling them in for expert-led workshops in person, which of course COVID has completely stopped, but it was never possible or scalable even in the past. And I think this is the kind of innovation that we need to embrace if we're going to go beyond the usual slogans of integration and community care to actually translating this into real-world action.
Thank you, Vikram. Old-fashioned approach, we need something new, and we've been talking about for many years how it has not worked, so we need something new. That's a revolutionary idea, I guess, and I'm sure you will push that from your side. Now, Maritu, our final speaker, again, what is the way forward and the steps that you see for us to proceed?
Great. So let me begin by saying this. As a global epidemic, it will take all of us to recognize mental health and enable access to all who need it, because they do deserve it. As public health practitioners working on maternal, perinatal, and child health, our role is not to focus just on the physical health, but to implement a patient-centered approach where the holistic need of the individual is addressed. I just wanted to say that from the outset, just maybe remind us all of our role, the critical role we have to move this agenda forward. As we move forward, the critical elements that we need to address, and these are my call to not only all of you, but all decision makers in developed and in developing countries. Advocacy remains a key to bring the leadership and decision makers to the table and commit to address this global epidemic. As we move forward again, as implementers, mental health and psychosocial support should be reflected in our program, focusing on strengthening the health system first. Well, it could be in parallel as well. Some people will say that, but beginning with the health workforce, with more training and collaboration with academic institutions. We need to train the people who are going to be the one providing these services. I'm also calling on all of us to take a stand and fight this pandemic that is negating decades of progress, saving lives. We cannot touch it because we certainly do not have the tools yet to implement our metrics to get the data in hand to see the impact. Some may have some of the data, but I think with the pandemic that we were facing, the impact is even greater. Let's take action to hold policymakers, donors, program managers, and implementers accountable for this. We need greater flexibility in RMN-CHA funding to support the implementation of mental health programs, and policymakers to develop policies focused on mental health and increase domestic funding. We see this happening all the time in our programs around the world. People have funding for health, but are not able to address mental health. And that is an oversight, and that we need to correct. Let's not make this last gathering the last one. I call for the organization of a global call to action for mental health to focus on targeting donors, decision makers, and other leaders to reduce stigma, focus on awareness, policy development, and funding of mental health programs, including the availability of medication. And finally, let's learn something from COVID. COVID has brought us together. The entire world came to the table, and people are putting resources on the table. Although not enough, people are committing to put our money on the table and address this issue as quickly as possible. Mental health is a silent killer and deserves to be adequately funded. And I will stop my remarks there. Thank you, Will.
Thank you, Marito. Funding, you were saying a silent kingdom, we need an approach to bring key also policies and tools to the table. That's great. We have to wrap up the session. We ran slightly over time. I'm sorry for that and apologies. I think it was a very rich discussion. I would like to thank all of you for making time to be part of this discussion and answering the tough questions. And with this, I would like to hand over again to Genesis and thank you all for being part of this. Thank you.
Thank you, Will, and the entire panel. Thank you, thank you, thank you. And once again, thank you. What a fantastic panel filled with unique perspectives from folks who clearly share a passion for ensuring that we have evidence, collective action for maternal mental health, and what no one is left behind in the road to 2030. I would now like to introduce our final speaker of this technical consultation, Paul Bolton. But before I do that, I want to thank you for allowing me to serve as your Day 3 facilitator. I have learned alongside you over the past several days, and it has been a pleasure getting to know you. I look forward to furthering our discussions in the weeks following this convening and in the journey we have ahead of us as we embark on the important challenge of ensuring maternal mental health is and remains a global priority. Bolton is the USAID Mental Health and Psychosocial Support Coordinator. This is a new position within the agency to advance the size and quality of USAID's global work in mental health and psychosocial support. He brings more than 20 years of experience working in program design, implementation, and monitoring and evaluation with international and local NGOs and governments. Thank you for being here with us. Paul, please take it away.
I want to start by thanking those who made this first ever global consultation on maternal mental health possible. And that means our esteemed partners and collaborators, WHO and UNFPA, and to our own USAID Momentum Country and Global Leadership, and to the Maternal Mental Health Technical Consultation Planning Advisory Committee, who helped to shape the agenda and led so many of the sessions the past few days. Those who have been particularly critical to this success include Becca Levine of USAID, and at MCGL, Shannon McNabb, Suzanne Stalls, Laura Fitzgerald, Anam Bhatti, Charlene Reynolds, Anna Petrusel, Nina Kadkar, and Edward Kenny. And I want to thank all of you who participated and moderated and presented. Thank you for being open and honest and willing to challenge the status quo. It is clear that there is interest and passion in moving maternal mental health, which I find inspiring. I feel confident that we will continue to make progress and ensure that maternal mental health remains a priority on the road to 2030 and beyond. This week, we had over 1,000 colleagues attend our sessions from 89 countries, and we continue to get updated data and analytics by the moment. At the end of this third day, I just want to take a few minutes to reflect on some key points that came up during the consultation and that I thought might be worth some extra emphasis as key principles for future programming. The first is focusing on family-based intervention. Throughout the world, the family remains the main refuge and source of support, or the main source of harm for most people, including women and mothers. For many women in the world, their main mental health problems, sometimes their main problems, include the mental health problems of their husbands, their fathers, their brothers. By also identifying and addressing the problems of men in families, we can help them to be more of a source of help than of harm in women's lives. Addressing the mental health of mothers and other family members will have more impact on the mental health of mothers than working with the mothers only. Second issue is that we need stepped care. We need broad-based programming of psychoeducation and skills building to help all people deal with stress, particularly in this time of COVID. But we also need to identify those who have mental conditions and need specific mental health interventions, like versions of cognitive behavioral therapy and interpersonal psychotherapy. Too often in the past, we have seen programs that only deal with stress broadly, but do not provide these more advanced treatments to people who need them. So it was wonderful to hear about programs and policies that provide them. This is real progress. Finally, I'd like to say a few words about the time we shared together, the connections forged, the learning and stories shared, and the collective vision of better mental health for all mothers everywhere. We know that maternal mental health is too often a secondary consideration after physical health, or even not a consideration at all. But as the moving opening video in day one reminded us, maternal mental health is not just a luxury. All women deserve good mental health. We know that there is no maternal health without maternal mental health. So we've reaffirmed our commitment and beliefs that mental health is a basic and fundamental human right and central to human dignity. Our work is now clear: to create a future where women are unafraid to talk about their mental health concerns, and where family, community, and healthcare providers stand ready to listen to and support them, and where addressing mental health is a normal and central part of high-quality, respectful healthcare. Today, we discuss the opportunity to build on existing efforts and action plans on the road to 2030 in the mental health and RMNCAH communities to chart a plan and action steps that are specific to the unique challenges and opportunities present in the perinatal period. Today, we also talked about our global experience of COVID-19 and the ways in which the pandemic has exacerbated mental health challenges for women and for healthcare providers. Innovations used to address these challenges offer important lessons on how to recognize and address stress, burnout, anxiety, and depression. We know that an essential part of doing this work will be tackling the stigma associated with maternal mental health, a stigma that keeps these issues in the dark and leads to silent suffering for too many women and families around the world. A stigma that extends to all levels of society and even to our political leaders who reject the data before their eyes on the importance of mental health. As we heard from our speakers, advocacy and awareness raising must be central to the plans and conversations we take forward from this technical consultation. It's up to each of us to harness this energy, these conversations, and this sense of urgency, to work together, committed to taking this vision forward, to relieve the silent burden of mothers around the world. Immediately following this technical consultation, you will be receiving a survey which will help inform future priorities for this important work. This is an important means to add your voice to ongoing efforts and planning to come. But the technical consultation is not over yet. We encourage you to join for our final social networking session, where we will be able to engage with fellow participants and continue to get to know each other. Thank you all for being here, and thank you for your commitment to making maternal mental health a priority.